Restorative treatment of the malpositioned dentition is presented by Dr. Antonio Mancuso and is supported by SciCan, makers and distributors of high-performance products for dental professionals.
Today we'll be discussing the aesthetic restoration of the malpositioned dentition, or as it is often referred to as instant orthodontics. Because of the increased demand for aesthetic dental services over the last decade or so, more and more of our patients are presenting with the need or the want of aesthetic restorations as an alternative to traditional orthodontics. But it would be prudent to at least have the patient get a consultation from an orthodontist, or at least discuss orthodontics as a viable treatment option for them. The other thing that would be prudent to discuss with the patient having a malpositioned dentition is the potential risk of endodontic therapy on the severely malposed teeth. In starting the case, it is important for us to have a thorough diagnosis and treatment plan. Now, the diagnosis is based on our comprehensive examination, our radiographic survey, study models, the dental aesthetic assessment form that I prescribe to, or any aesthetic form that you wish to follow, digital photographs if you wish to simulate the case, and other photographic means, surveys such as the American Academy of Cosmetic Dentistry, 12 required views, and other photos that would augment your photographic survey. Also, from the study models, it is prudent to get, based on the information gathered in the dental aesthetic assessment form, a diagnostic preview for the patient. I have found that the diagnostic preview is the best way to communicate to the patient on what the potential outcome may be. So today we're going to be treating Jerry, our patient. We're going to be doing the restorative treatment of the malpositioned dentition as opposed to traditional orthodontics. There are four aspects to the restorative treatment of the malpositioned dentition that I'd like to go through prior to us starting with Jerry. The first aspect of the treatment is to get proper arch form. And proper arch form entitles us to remove, or lets us remove, any of the excess labial material that is outside the arch form, in conjunction with the removal of any excess material on the lingual aspect, so that when we finish we have proper arch form, utilizing a piece of floss that goes over the cusp tips of our buccal segment. So that's the proper arch form that we want to attain prior to us starting our next step. The next step will involve getting proper tissue heights, and we'll be using a diode laser today. And as you can see on the model, we've outlined in red the exact type of architecture that we want to attain using soft tissue gingivectomy procedures. We want to get proper gingival symmetry, gingival contour, and gingival zenith. Thirdly, we'll be going through all the interproximal contacts and break interproximal contacts. That is probably one of the more often forgotten steps in treating this type of dentition. And the reason why you want to go through the interproximal contacts is to allow us the ability to create golden proportion. So after the proper interproximal slicing has occurred, then the last step will be our actual tooth preparations. So Jerry has already been pre-anesthetized, and we're going to commence with treatment today. So the first step that we're going to be doing today is remove all the excess labial tissue so that we can get a proper arch form. Now that we've finished the labial reduction, we're going to go into the lingual reduction, specifically tooth number 2-1. And you can see now, after the initial arch form recontouring, we're getting a little bit better semblance of what ideal arch form should be. We'll finalize the finalization of arch form when we do our individual preparation, but this gives us a little bit of a guideline as to ideal arch form. Okay, our second phase of the treatment of the malpositioned dentition will be involving gingival recontouring. We'll be doing that with our diode laser. Suction. So we're just about finished with our gingival recontouring. We're trying to get gingival symmetry between the 2-1 and the 1-1 gingival heights. Also, we're paying attention to the gingival contour and the zenith on the laterals so that we have a nice flow of the gingival architecture once we're done with the case. Okay, now we're ready to commence with our third phase of today's treatment, and that will be involving the slicing of the interproximal contacts. Okay, Jerry. Okay, Jerry. Now that we've broken our contacts, we're going to commence with our actual individual tooth preparations. Now, one of the things I wanted to do to tooth number 1-3 is get more of a medial axial inclination, so my preparation is going to be a little heavier on the distal aspect so I can reorientate the porcelain in a more mesial fashion. I'll go to the next one now, Jerry, okay? If you feel this one, let me know, okay? Now, tooth number 1-2 is fairly lingual-verted relative to the 1-3 and the 1-1, so therefore it will require minimal reduction on the labial aspect and a little bit more of an orientation from the lingual, bringing it labially. So we'll be doing a little bit more of an incisal third reduction on the lingual aspect of the third of the tooth. One of the keys that you want to always look for is in your articulation, making sure that the lower dentition does not contact at the juncture of porcelain and natural tooth structure. So once in a while I always have the patient close down to reevaluate that position. And open again. Good, and bite down again. Great, thank you. That's good, and open again. Good. Just like in the tooth number 1-2, tooth number 2-1, because of its lingual positioning, will require minimal labial preparation. All you really require is a good heavy chamfer, approximately down to the gingival margin, if not slightly supragingival. In repositioning the 2-1 more labially, you have to envision the way the porcelain is going to be coming out labially. So you want to be able to remove any of the incisal aspect of the tooth structure that would inhibit the proper placement of the restoration. So you can see my angulation of my burr is almost parallel to the floor relative to the tooth structure. Now, in treating the upper bicuspids, the first bicuspids that is, experience has dictated to me that I typically find them more lingually verted than ideal arch form, and so the labial aspect really does not require a heavy reduction at all. It would require just a solid chamfer down the gingival margin and then slight overlapping of the incisal cusp tip so that it does not interfere with the occlusion. At this point that I finished my gross reductions, I like to revert to higher magnification, and I put on high magnification loops with a light source so I can finalize the gingival margins of all the preparations. Okay, and now that we're finished with our reductions, what I like to do is remove any line angles that are sharp on the preparations, and for this we use a sandpaper disc. We don't want any stress propagation through the porcelain with sharp line angles. You want all your internal preparations, internal lines to be rounded. One of the last things that I always recommend to clinicians to do, especially if they're right-handed operators such as myself, is get a different perspective of your final preparations prior to impression taking. So at this juncture, I usually like to stop, get up, and go to the 6 o'clock position and look at the preparations, so that way you can judge to see if any of your preparations are leaning to one side or the other, and then you could make the necessary adjustments. You can see we've got proper gingival symmetry between the 2-1 and the 1-1. We've recontoured the gingiva on the 1-2 and on the 2-2, so we got a little bit nicer gingival contour and zenith. Our preparations are such that we are able to have nice arch form as opposed to the malpositioned arch that Jerry started with today. And if we can get Jerry just to tilt his chin up just a wee bit, we can see, there we go, how much reduction was required on the labial aspect, specifically number 1-1, and on the lingual aspect, specifically number 2-1, so that we could orientate the porcelain in a more ideal arch form. So now at this stage we're going to be getting our taking our stump shades and then commencing with impression tape.